Today we're going to be doing a skills presentations for the methodology course. Today we're going to be talking about the BVM ventilation of an apneic patient. So in this skill, what we have is an apneic patient, someone who is not breathing, but they do have a pulse in this case, and we want to control their airway. So how are we going to do that? Well, we have a few tools to help us out at the basic level to help control this patient's airway. I'm going to go through a couple of them real quick. One, the first is the MPA. We have a few different sizes here. We're going to go over that. The MPA is a nasopharyngeal airway. This device is actually a soft plastic hollow tube, very flexible, just like that. It's got a bevel tip and a trumpet on the other end. Opens up. See that? Right there. Okay, and what this does is it goes into the nostril through the nasal passageway and back into the oropharynx, where it will, or nasopharynx or oropharynx, depending on how deep it actually goes. But what this does is it provides a clear tube, obstruction-free, to allow for a clear airway passage through the mouth, or well, in this case through the nose, but to the back and the opening of the larynx into the airway. So we'll go over insertion of that in a little bit. Another device or option for an airway adjunct would be an OPA, or an oropharyngeal airway. These OPAs are harder plastic. They're used in the oral airway in the mouth. You can see here it's got a little bit of a crook to it and a mouth. So to do that, we'll go over that in a minute, but that'll go into the mouth. And what it actually does is, you see that hook there will hold the tongue right there. This is actually, if you can see, when it goes in, it will hold the tongue from falling and prevent it from falling back and occluding the airway. Now, the tongue is the most common cause of airway obstruction in an unconscious person. So this is a big deal and a big issue for us, and this is a great tool. But you can't always use the OPA. When you can't use it is someone who has a gag reflex. They could be unconscious but still have a gag reflex, and that's when we don't want to use this, because the last thing we want to do is cause someone to aspirate vomitous material, causing pneumonia, and that's not going to be too happy or too good of an ending potentially for them. Now, another tool we'll look at today is we have a portable suction device. We have a Yonker, a hard tip suction catheter with some suction tubing. We're going to use this just in case. Anytime when you're managing an airway, if there is fluid or vomitous material in the airway, secretions, you can take care of that using this device, and we'll touch a little bit of that later. We're just going through right now, introducing to the equipment. And lastly, our BVM, our bag valve mask. This actually has a mask seal. It detaches, hooks up to the BVM. Anytime we're using a BVM, we want to hook up to at least 15 liters high flow to 15 liters per minute. O2 line will hook up here, and we can provide positive pressure ventilation that way. So, when do we use this? Well, this is an apneic patient. Our patient is unconscious. They're apneic, meaning they're not breathing, so we need to breathe for them. And at this basic level, we're going to use these adjuncts and with the BVM and suction as needed to help control it and oxygenate. Why do we need to do this? Well, we all need oxygen, okay? And if a person is unresponsive or apneic and not breathing correctly, then their body's not bringing in good oxygen. And what happens when you don't bring in the oxygen is your tissues and cells, they don't work good. They need this oxygen to survive, and so we want to provide that for them. Also, your tissues, while they're still working and stuff, they're producing waste, they're producing CO2, and these things are toxic and harmful to the body, so we really need to get them out of our system. So by providing ventilations for them and breathing, we put air in and we're taking the bad stuff out. So we're giving the body the good to help it sustain and give this person a better chance, and we're taking out the bad, which is also helping them along the same lines. So first things first, we've done our assessment. Is this person responsive or unresponsive? Look, listen, and feel. And what we're going to find in this particular patient is that they are unresponsive and they are apneic. They do have a pulse, but they're unresponsive and they're apneic. Okay, so in a truly unresponsive patient, we normally, you wouldn't think they would have a gag reflex, so we would try an OPA. But first we need to open the airway. And there's 2 ways of doing this. One with the trauma. If there is trauma suspected, we do what's called a jaw thrust maneuver. Just like you were manually inline stabilizing the neck here, we're going to come in and try to hold stabilization, but using our hands and fingers to lift up on the jaw. And in the corner of the jaw right through here, we can actually lift up on it without manipulating the neck any or going into a sniffing position. We can lift up and help open